everyone. On behalf of Cambridge Health Tech Institute's Global Web Symposia and our sponsor for today's webinar, Biomodels, I'd like to welcome you to Predictive Preclinical Animal Models of Pulmonary Disease, Acute and Severe Asthma, Pulmonary Fibrosis, Acute Lung Injury, and Acute Respiratory Distress Syndrome. My name is Elizabeth Lamb, and I'll be your host and the moderator for today's event. With that, I would like to introduce our presenter for today. She is Dr. Paulette Wright-Andreatta, lead pulmonary scientist at Biomodels. Welcome, Dr. Andreatta. The presenter ball is yours.
Great, thank you very much. I just wanted to start with a little bit of background on Biomodels. So we are a preclinical contract research organization, and we're located in Watertown, Mass. And we were founded in 1997 out of the Brigham and Women's Hospital here in Boston. And what we've done is we've conducted and developed highly translational models of human diseases and conditions for a wide variety of clients. Our goal is really to transition these drugs and biologics from concept to patient. So I'm happy to say that we have many successful stories of being able to do this. We've been able to facilitate 41 compounds into patients for multiple indications. And our therapeutic expertise within the company ranges from inflammatory diseases, autoimmunity, oncology, pulmonary disease, fibrosis, cardiovascular disease, metabolic disorders, neurology, and psychiatric disorders, as well as cancer supportive care, which is what our company was founded on. So just the objectives for today's webinar are I'd like to go over the respiratory model endpoints that translate to the clinic. And then I'm going to give you an overview of respiratory models that we currently have developed at Biomodels. They include several models of acute allergic asthma, that being the ovalbumin model, the classic model, as well as the MITE model, which is a little bit more physiologically relevant, and the cockroach allergen model, which is very similar to that. In addition, we've been working on a newer model of severe asthma, as well as several models of acute lung injury that include installation of hydrochloric acid, as well as an LTS model. And lastly, I'll be talking to you about a bleomycin-induced lung fibrosis model that we have running and the various endpoints that we have established for that. More recently, we've been able to establish a correlative to the in vivo model, our in vitro TGF-beta stimulated fibrosis model, to help support some of the in vivo modeling. And this uses a normal human lung fibroblast in culture. So there's a nice human component there. Some of the criteria that we try to target when we are developing our translational modeling are that our model must replicate the clinical condition. The underlying biology should be the same or as similar as possible to the human pathology. And ideally, the model is cost-effective and provides actionable information. So the endpoint should also be translatable to those used in clinical trials, so it needs to be relevant. And we always like to keep in mind that the value of the model lies in the quality of its predictions. Some of the common clinical endpoints for lung diseases are, such as in IPF or COPD and asthma, include mainly three parameters. So one being biomarkers, second being lung function, and the third being exercise. So these are three typical things that are looked at in the clinic. So biomarkers are typically evaluated in sputum or serum samples, and these include things like looking at different profiles of inflammatory cells, as well as inflammatory mediators, so cytokines and chemokines. For lung function, a very common and standard endpoint is the forced expiratory volume, or FEV1, and this is a measurement of how air is exhaled during the first second of a forced breath, and this is measured in patients using spirometry. Additionally, they can evaluate forced vital capacity measurement, and this is the total amount of air exhaled during an FEV test. Along with this comes measurements of airway resistance and lung compliance. And lastly, they typically look at exercise, or the measures of the 6-minute walk test and endurance tests in the clinic as endpoints. Just to give you an idea of how we look at biomarkers in our animal models, we collect bronchoalveolar lavage, or BIL, from animals. We do this by cannulating the lung and basically washing the lung out with PBS. The fluid is collected and the cells are spun down. We can evaluate total cell counts in these samples as well as differential cell counts. On the right-hand side here, I'm showing you examples of the BAL cell count. This is a cytospin from a naive animal. We receive very few cells, and these are mainly macrophages. On the right here is an LPS cytospin from an LPS challenged animal, where you see predominantly neutrophils, and this is clearly showing you a nice increase in total inflammatory cells in the BAL. Additionally, we can use the supernatants from these samples to evaluate inflammatory mediators such as cytokines and chemokines, as well as total protein. So this would give us an indication of vascular leakage. Additionally, we can look at serum and lung homogenates from animals and also evaluate inflammatory mediators. Lastly, we can also look at biomarkers using histology. So the way we do this is we collect lungs, they're insufflated in formalin, and then they're embedded in paraffin in sections. So we can do various stains with these samples, the most routine being the H&E to evaluate pathology and inflammation. We also do more specific staining, such as the Mason's trichrome for collagen deposition, and this pertains to our fibrotic model. And then PAFs are for a mucus stain in our asthmatic model. We additionally do immunohistochemistry to evaluate markers of interest. So here on the right, I'm showing you just an example of our lung histology with the trichrome staining in naive and a bleomycin-induced animal. You can see nice fibrosis deposits of collagen in the bleomycin-induced lungs. We also evaluate lung mechanics in our animals using the flex event system, which was developed by CIREC. So this uses the forced oscillations to conduct its measurements of lung function. Mice are anesthetized and tracheotomized. They are ventilated on the flex event, and this is computer controlled. And the rodent is under a mechanical ventilator. So this allows for ventilation of the mouth and forced oscillations. And we can measure several perturbations, such as pressure volume curves, broadband forced oscillations, and also conduct nebulized METHACHOLINE challenges. So here, from the pressure volume curves are where we apply a quasi-static increase in lung volume at the airway opening. This measures increases in airway pressure as a function of lung volume. And so here I'm showing you an example of a pressure volume curve in a naive versus a bleomycin challenged animal. And as you can see, the bleomycin induces a shift in the pressure volume curve that is towards the right and down. This implies an increased stiffness of the lung. So from this measurement, we can look at clinically relevant outcomes such as lung compliance and elastance, where lung compliance is the change in volume over the change in pressure in the lung, and the elastance is 1 over compliance. We can also evaluate vital capacity, which is equivalent to lung volume at 30 centimeters of water, as well as the work of breathing. Furthermore, we can use forced broadband oscillations that are applied at the airway opening to measure pressure and flow. So this is a more complex analysis using fifth parameters and what they call the constant phase modeling. So this is specific to central airways and peripheral changes in lung mechanics. So the outcomes of these measurements can give you airway resistant measurements of the central airways, and this is more relevant to changes such as we see in allergic asthma. Additionally, we can evaluate tissue elastance and tissue damping with this parameter, tissue elastance and energy dissipation. And these are parameters that are relevant to changes in lung function during acute lung injury, where there's stiffening of the lung, or COPD, where there's a loss of elastic recoil in the lung. Lastly, using the lung mechanics measurements, we can evaluate the METHACHOLINE challenge and determine airway resistance in our animals. So this is very applicable to the allergic asthma models that we have. We challenge the mice with increasing doses of methacholine, and then we measure lung properties with forced oscillations. And we can represent this data either as peak values, as shown here, down on the bottom here, or as area under the curve. And as you can see, there's a dose-responsive increase in airway resistance in the animals that we challenged with OVA, so this turquoise line here, compared to naive, which is the pink line. And then if we treated our animals with dexamethasone, we see a decrease in that airway resistance that is also dose-responsive. So lastly, we can look at exercise in our animals as well, using our wheel running in mice. So wheel running is shown to be reduced in animals where they have damaged lungs, and this reflects fatigue as well as degradation in lung function. So here I'm showing an example of animals that were irradiated with thorax, and they display decreases in running distance over several days, implying fatigue and degradation in lung function. And this is a surrogate to the 6-minute walk test or endurance testing that's done in the clinic. We can also apply forced exercise in mice modeling to look at this as well. So just to give you a brief introduction to asthma. So human asthma is characterized by chronic pulmonary Th2 inflammation. This is predominantly eosinophilic. As shown in this diagram here, upon allergen challenge and specifically to allergic asthma, we have an influx of inflammatory cells. This is followed by the production and secretion of inflammatory mediators, such as Th2 cytokines, which are predominantly elevated in asthma. So that includes IL-4, IL-5, and IL-13, most importantly. The influx of these inflammatory cells and mediators leads to physiological changes in the lung, such as mucus oversecretion, vasodilation, airway constriction, and this ultimately can lead to remodeling in the asthmatic airway. To date, there's more than 25 million cases in the U.S. that have asthma, and this results in a direct or an indirect cost of approximately $56 billion or more a year in a clinical cost. Mild to moderate asthmatics are well controlled with their therapeutics. They typically take a low-dose anti-inflammatory or inhaled corticosteroid, as well as a long-acting bronchodilator. However, there are about 10% of asthmatics that do not respond well to inhaled corticosteroid treatment, and therefore they either receive high levels of corticosteroid treatment or oral steroids. And this population of asthmatics is considered to be severe asthmatics, and their profile includes a mix. We're finding more about this population of asthmatics, but their profile seems to have much more neutrophilic inflammation, as well as a Th1, Th2 mixed profile, and an IL-17 activated pathway. The models that we have developed in the lab for acute allergic asthma include, as I mentioned, the ovalbumin classical model, as well as the host dust mite model and the cockroach allergen model. So I'm going to go into a little bit more detail about these in just a bit, but just to show you that we can develop these both as acute models as well as chronic models. So typically up to 16 or 14 days, but we can make them chronic models and take them out to weeks, several weeks, 12 to 7 weeks. The endpoints for these models include total and differential cell counts in the BAL, detailed lung mechanics using the flex event, as well as inflammatory mediator content, so cytokines and chemokines, histopathology, and mucus production. This is how we run our OVAL model of acute allergic asthma. So the animals, VALC mice, are sensitized to ovalbumin using a 20 microgram dose per mouse, and that's with an alum at 1.5 mg per mouse on days 0 and 7. These are IP sensitizations. Mice are then challenged on days 13 to 15 with 20 micrograms dose of OVA, although we've gone up to, this ranges sometimes for us, depending on client requests. So they're challenged with this intranasally. And then we can use positive controls such as dexamethasone or test article treatments, and these are generally dosed between days 12 and 16. The endpoints are conducted on day 16, and they include the BAL, so total and differential cell count, as well as multiplexing for inflammatory mediators, such as cytokines and chemokines. We also collect the lung for histology and or protein. We also look at RNA and we evaluate inflammation and mucus production, typically using histology. So lastly, we use the flex event to evaluate airway hyperreactivity by the METHACHOLINE challenge. So here is some data from our OVA model. This is looking at the total inflammatory cells in the BAL. As you can see, we have a nice significant increase in inflammatory cells in the BAL using either both the 25 microgram and the 200 microgram dose of OVA. And this is predominantly eosinophilic, so we have a good amount of eosinophils in the BAL. And then we are able to show a significant reduction in total inflammatory cells and predominantly eosinophils using dexamethasone treatment. Here's some histology recapitulating that the same effect, an increase in total inflammatory cells and a nice reduction with the dexamethasone treated group. We also evaluate lung mechanics. So here's the METHACHOLINE challenge, looking at airway resistance measures over a dose response of methacholine. So OVA challenge is able to induce airway hyperactivity in terms of airway resistance and tissue elastance. So here's the resistance and here's the elastance. We see a nice induction with the OVA challenge animals that is then reduced with the dexamethasone treatment, shown here with resistance as well as elastance. Additionally, we can treat. We have a house dust mite model of acute allergic asthma, and we can also use some positive controls in this model. So this is a very similar model to the OVA model, but it sensitizes animals intranasally rather than IP, so it's considered to be more physiological, if you will, to what occurs typically in asthma or how we generate asthma. So BAL-C mice are sensitized to house dust mite extracts, and here we're using 50 micrograms per mouth on day 0 and 7. The animals are then challenged on day 14 with 25 or 50 micrograms per mouth of house dust mite. And then our positive controls or test articles are typically dosed on days 13 to 16. Here we've used either dexamethasone, which was dosed 2 hours prior to house dust mite challenge on day 14, or fluticasone, which was dosed at -1 hour or +6 hours on day 14. The endpoints for this are the same endpoints that we've used for the OVA model. So inflammation, we've looked at total inflammatory cells in the BAL with both the 20 microgram house dust mite and the 50 microgram house dust mite doses. We see a nice increase in total inflammatory cells. With the dexamethasone treatment at 3 mg per kg, we see a nice reduction in the total inflammatory cells, as well as, and this is similar effects we observed in eosinophils, as well as the neutrophils. And down here, I'm showing you another study we conducted with the fluticasone treatment, where we do also see a nice reduction in total inflammatory cells. We also evaluate inflammation using histology, so our H&E. We see a significant increase in multifocal inflammation within the alveolar space when we challenge our animals with the house dust mite model. So in the black arrow here is showing the alveolar space inflammation, whereas the red arrows are showing the inflammation within the vasculature. Additionally, we evaluate mucus by looking at PAS-positive goblet cells. So here in the house dust mite challenged animals, we see nice positive staining for our goblet cells, indicated with the green arrows. These cells are not positive, so there's a lack of PAS staining in our control section. Not showing it here today for the sake of time, but our histology of the fluticasone and dexamethasone treated lungs also showed a nice reduction in inflammation, consistent with the reduction in BAL total cell count. However, the goblet cells were still present. We've also evaluated cytokine levels in these animals challenged with house dust mite. So we see a nice increase in our Th2 cytokines, IL-4, IL-5, and IL-6 in our house dust mite challenged animals, and a nice reduction with both our dexamethasone treatment and our fluticasone treatment for all three of those. I've included here levels evaluated of a Th1 cytokine, IL-1 beta, which are not altered across any of the groups. We also look at airway resistance in these animals. So similar to the OVA model, we see a nice increase in methacholine challenge dose response in the house dust mite challenged animals, indicating hyperresponsiveness in their airways. And that's indicated here with the turquoise line, and that's as compared to control, which is the pink line here. Again, treatment with either fluticasone or dexamethasone reduces that airway hyperresponsiveness, so the resistance is reduced. It seems as though the dexamethasone here at this dose is showing a better efficacy than fluticasone. So as I mentioned at the beginning, we've recently developed a more severe asthma model using house dust mite. So this is still under development. We've used BALB/C mice that are sensitized to house dust mite extract on day 0. We've used a 50 microgram dose, and this is in complete steroid adjuvant, so CFA. They're also challenged on day 14 with the same dose, but this is given intranasally. And then generally we would, again, use our positive controls between days 13 and 14, and then endpoints on day 16. So the endpoints are the exact same endpoints that we've used for the previous acute model. Here we are looking at total cell counts and differential cell counts in the BAL. We see a significant increase in inflammatory cells in the BAL with our house dust mite challenged animals. And these are both eosinophils, but we also see an increase in neutrophils. And as I mentioned to you, this is the profile switch in severe asthma, where we have a mixture of both Th1 and Th2, or eosinophilic and neutrophilic inflammation. They also evaluated inflammation and mucus production by looking at our histology, so H&E and PAS staining. In these animals, we see nice increase in perivascular and peribronchial inflammation with our house dust mite challenged animals. So the red arrows indicate those areas here. And furthermore, we do see PAS positive goblet cells, indicated here with the green arrows, in our house dust mite challenged animals that are not present in our saline control. We did a nice evaluation of cytokines, profiling them for both Th1 and Th2 in the BAL of these animals. We see a nice increase of Th2 cytokines and as well as eotaxin, so IL-4 goes up, IL-5, as well as IL-6. We also see an increase in Th1 cytokines, which we don't see in our acute model, and that includes interferon gamma, IL-12, P40, P70, as well as IL-17. We also looked at lung mechanics in these animals, so they do display an increase in airway resistance as compared to naive animals, and this is our dose-responsive methacholine challenge. Here are the house dust mite challenge animals. So in summary, for our mouse models of allergic asthma, I've shown you several models of acute allergic asthma, OVA being the most traditional, which recapitulates most hallmarks of the allergic asthma in humans. It's primarily eosinophilic, and it's most well-characterized model in the field. The house dust mite and the cockroach allergen models are more physiologically relevant. However, they do require adjuvant, and they do present some neutrophilic inflammation. We were able to show that dexamethasone as well as fluticasone serve as reliable positive controls in these models. And I've showed you just some more preliminary data in the development of our severe asthma model, where the inflammation that we are observing is both eosinophilic and neutrophilic, and we're observing a mixed Th1, Th2 inflammatory profile. The airways are hyperresponsive in these animals. We evaluated this with the methacholine challenge and also looked at mucus. We have not thus far evaluated if this model is steroid insensitive, but we are doing that currently. I just think one thing to keep in mind throughout all these models is that the duration, the sensitivity, and the challenge can be customized to fit different therapeutic applications. So moving on to our mouse models of acute lung injury and acute respiratory distress syndrome. So acute lung injury, just to give you a little background, is characterized by hypoxemia, pulmonary edema, low lung compliance, and widespread capillary leakage. It affects about 175,000 Americans annually and has about a 30 to 40% mortality rate. So the common causes of ALI are pneumonia, sepsis, aspiration, and trauma. And in humans, it usually requires mechanical ventilation, and this certainly can increase the risk of ventilator-induced lung injury. So the models that we have developed are the hydrochloric acid instillation model, where we instill this directly into the trachea. 0.1 normal HCl is used, and we evaluate the model up to 96 hours. We also have an LPS-induced lung injury model. This is either given intranasally or intratracheally, and it acts as a TLR4 agonist, and we evaluate this between 4 hours and 7 days. The endpoints for this are total and differential cell count, lung mechanics, histopathology, and BAL for inflammatory mediator analysis, etc. As I mentioned, here's the HCl-induced acute lung injury model, where we instill 0.1 normal HCl directly into the lungs with an intratracheal administration. These animals are under isoflurane. And then 24 hours later, we assess we evaluate cell counts and total protein in the BAL, and as well as lung mechanics. So here's the total inflammatory cell count, as well as differential cell count. In the lungs, we see a nice induction of total inflammatory cells. This is a dose response of HCl given to the animal, and this increase in total cell count is predominantly neutrophils. And then we also evaluated total protein. So we see a nice increase in total protein, which reflects the vascular leakage of plasma proteins into the alveolar space, and this is direct correlate to pulmonary edema. Using lung mechanics, we've evaluated several parameters in this model. So we've looked to see the dose response of HCl and how it affects the PV loop. So we see a nice dose responsive increase in the rightward shift of the pressure volume curve. So you can see that here, where it's shifting as we go up in dose. And then the hydrochloric acid also induces a stepwise increase in lung stiffness. We've also evaluated the lung elastance here and see a nice dose-responsive increase. We've also used an LPS-induced model of acute lung injury to simulate the presence of negative bacteria. So this is an endotoxin that's present on the outer membrane of gram-negative bacteria. LPS can induce a TLR4-mediated inflammatory response, and it serves as a good model of the host innate immune response. And it can, LPS induces lung injury, and it often serves as an acute screen for chronic neutrophilic inflammatory disease, so a surrogate for COPD. So here's the schematic of the model design. The animals receive an intranasal dose of LPS at time 0, and then we evaluate endpoints at various time points. So 24, 48, and 72 hours are the ones that we typically look at. As a positive control, we can use steroids, and these are typically given between -1 hour and up to 72 hours. Again, the endpoints include BAL for total differential cell count, cytokine and inflammatory mediators, lung elastance and airway hyperactivity, lung histology, and serum. So here we've looked at BAL lung inflammatory cells over time in this model. So we can see a nice increase over time of inflammatory cells coming into the BAL. It seems to peak around 48 hours. These are predominantly neutrophils. And we've also looked at a Th1 cytokines, so IL-1 beta, which also seems to peak at around the same time of 24 to 48 hours, and then begins to resolve. Here I'm showing you just some correlating histology of increasing doses of LPS, where you clearly see a nice induction of inflammatory cells at the higher 10 microgram LPS dose. So we've looked at lung mechanics in these animals over time. So again, a time course of after LPS installation. We see a shift of the PV loop over time, where it seems to, the biggest shift is at 48 hours compared to the naive control, where it starts to then move back towards the naive, where the response is resolving. This correlates well with lung elastance measurements. So we see a nice increase at peak at 48 hours that starts to resolve at 72 hours. So our treatment paradigm is shown here, where we can treat with dexamethasone. We use our intranasal administration of LPS at time 0. And then we treat on day 0, as well as 24 hours after installation with our 3 mg per kg dexamethasone dose, and endpoints are collected at 48 hours. So here we're looking at neutrophils in the BAL. You see a nice induction with our LPS alone animals, and then the animals that were treated with dexamethasone show a nice decrease in neutrophils. This correlates well with IL-6 levels in the BAL, as well as interleukin-1 beta levels. And histology shows a nice correlation with these data, where the LPS alone group shows a nice induction of inflammation. Dexamethasone-treated group inhibits the inflammation in the lung. And lung mechanics on these animals show a nice reduction in lung elastance with dexamethasone treatment, and a nice shift back towards naive in the LPS dexamethasone-treated group. So this is the light blue color here. So in summary, for our acute lung injury model, we've been able to validate 2 clinically relevant models of ALI, ARDS. Hydrochloric acid induces a model that replicates necrotic insult to the pulmonary epithelium. So this is similar to what we see with inhaled toxicities or aspiration of stomach contents, which is very acidic. LPS induces a model that simulates innate immune responses, so things like pneumonia and sepsis. We've been able to characterize both models with regards to lung inflammation, histology, cell counts, and cytokines, as well as detailed lung mechanics. And dexamethasone treatment serves as a reproducible control for testing an anti-inflammatory compound. So moving on to human pulmonary fibrosis, a little bit of background on this disease. So pulmonary fibrosis is a progressive fatal lung disease, and it's characterized by lung damage and scar tissue formation. So they typically call this honeycombing. And as a result, lungs become stiff and difficult to inflate, leading to irreversible loss of lung function and ultimately death. It can be idiopathic in nature, or it can arise from risk factors. And this can include things like smoking or radiation therapy. It affects approximately 132,000 people per year in the U.S. alone, and the median survival time is 4.2 years. Additionally, there are about 50,000 new cases diagnosed every year. So the approved treatments, which have only recently been approved since last year, are pirfenidone. This was previously approved in the EU and Canada, but only was recently approved in the U.S. Nintedanib, or OFEV, was also recently approved around the same time last year in the U.S. It's known that TGF-beta is a predominant or key mediator in contributing to pulmonary fibrosis and fibrosis in general, and that there's a mediated communication failure between TGF-beta and the epithelium and mesenchymal tissue, and this can result in chronic activated fibrotic pathways. So I'm showing you some of the pathways that are activated here with TGF-beta, and this can lead to excessive lung deposition by myofibroblasts that are in the lungs, as well as fibrosis, scarring, and degradation of lung function. Here I'm also showing you the endpoint of this fibrosis, where the honeycombing effect, where we see this morphology in the histology of the lung. So the animal models of pulmonary fibrosis that we have at BioModels include the intravenous bleomycin-induced pulmonary fibrosis model. And this is a lengthy model. It goes out to 42 days, where animals receive intravenous bleomycin for 5 days. We also have an intratracheal model, which is a shorter 21-day model, where bleomycin is delivered once directly into the lung via intratracheal administration. And then we also have a radiation-induced pulmonary fibrosis model, where they're irradiated with a single dose delivered to the thorax, and this goes out to 20 weeks. It's a much longer model. The endpoints that we use typically are the histopath, fibrosis scoring, detailed lung mechanics, so the flex event, hydroxyproline content, BAL inflammation, as well as mediator content. And we can do micro-CT imaging as well as endurance testing, so they'll be running. So here's the intravenous model. I mentioned to you that there's 5 instillations intravenous of the bleomycin, and then we take body weight and respiratory status daily out to 41 days. Here's the percent weight change that we observe in these animals over a dose range of bleomycin. So the mice demonstrate a dose-response weight loss in this model. And also we can evaluate areas of subpleural fibrosis, and this ends up being about approximately 30% of a section that you see here. This results in thickening of the alveolar wall with inflammatory cell infiltration of the histology. Furthermore, we evaluate whole lung weights, and you see here a nice increase in whole lung weights with the 20 unit per kg IV bleomycin group, statistical. We also evaluate lung collagen content using hydroxyproline, where we see here at the 2 higher doses of bleomycin, we have a nice induction of collagen in the lung. We also evaluate the pathology, so we look at the modified Ashcroft score system and evaluate fibrosis in these in the lung sections from these mice. We see a nice induction in the modified Ashcroft score. For our IT model, this, as I mentioned, is 1 instillation given intratracheally on day 0 of the bleomycin, and it goes out to 21 days, where, again, we measure body weights and respiratory status daily. However, in this model, we're not seeing a dose response in weight loss with the bleomycin. We do see an increase in whole lung weight with bleomycin, and this is how we can begin to choose our optimized dose of bleomycin for lot-to-lot variation. So here we're looking at lung collagen content, and we see a nice increase with bleomycin, as well as the modified Ashcroft score. So these parameters help us validate lots and choose our dose for subsequent studies. Again, looking at histology, see nice increases in fibrosis in bleomycin-challenged animals shown here. So again, like a honeycombing effect. I just wanted to point out a couple clinically relevant comparator controls that we've used in this model. So there are, as I mentioned, 2 FDA-approved therapies for patients with IPF, pirfenidone, whose mechanism is unknown. We know that it acts on the TGF-beta pathway to some extent. And nintedanib, which is also called OFEV, which is a tyrosine kinase inhibitor, and it targets multiple growth factor receptors such as PDGF, FGF, and VEGF receptors. So these are the 2 approved, and in development are multiple anti-TGF-beta antibodies, since it's well known that TGF-beta is a major mediator in lung fibrosis. So we've gone on to test 2 of these comparator compounds in our models. So anti-TGF-beta as well as pirfenidone. So this study was set up to have a sham group, a bleomycin challenge group, as well as an anti-TGF-beta treated group, and this was given IP at 3 mg per kg. And then our last group is a pirfenidone treated group, given at 100 mg per kg dose, and that was twice daily. And this model went to 21 days, and we evaluated several endpoints, including weight change, lung mechanics, micro-CTs, histology, collagen deposition using trichrome, and hydroxyproline. So percent weight change data, we saw a nice decrease in percent weight change in our control group, this red group here, the bleomycin control. And with treatment with anti-TGF-beta or pirfenidone, we were able to prevent this weight loss to an extent. Bleomycin also induces lung fibrosis, as we identified by H&E and this is trichrome. And we saw a nice reduction in the collagen deposition evaluated with the trichrome in both the anti-TGF-beta treated group as well as the pirfenidone group. We also saw a nice reduction in the monoxide Ashcroft score using both treatments for pirfenidone and anti-TGF-beta. There was a reduction in percent affected within the lung section, so percent affected with fibrosis. And there was also a reduction, although not significantly, of hydroxyproline content in the anti-TGF-beta as well as the pirfenidone treated group. Furthermore, we looked at pressure volume curves and saw in our control group, the bleomycin group, a nice increase or shift to the right and down of the stiffness of the lung that was prevented with anti-TGF-beta treatment as well as pirfenidone treatment, so shifting the curve back to the left towards the naive animal. We can also evaluate several parameters that go along with the pressure volume curve, so lung elastance, vital capacity, and work of breathing, which followed similar patterns. So anti-TGF-beta and pirfenidone treatment reversed the effect of the increase in elastance, vital capacity, and work of breathing. So lastly, I wanted to talk to you about a human in vitro model of TGF-beta induced fibrosis. So this brings in a human component to be able to evaluate compounds and their effect on fibrosis. So this is in support of the in vivo model. So the model design consists of our primary normal human lung fibroblasts, and they're plated at 130,000 cells per well on a 24-well plate. And once they're confluent, the cells are starved overnight, and then they're either treated with compound. We've used relaxin as a positive control, and then this is followed by TGF-beta stimulation. We've used between 5 and 20 nanograms per mil dose of TGF-beta. And then 48 hours later, supernames and cell lysates are collected for endpoint analyses. We can evaluate protein levels of procollagen, this is PIP, as well as plasminogen activator inhibitor, or PI1. And these are factors that are upstream of collagen and fibronectin, respectively. So things that lead to the fibrotic response. We've also been able to evaluate alpha SMA levels in the cell lysate as a marker of the development of fibroblasts becoming myofibroblasts. So these are the endpoints that we look at in the supernames. We also look at LDH for signs of cell toxicity, as I mentioned, PIP and PI1. Cell lysates we use for alpha SMA, as well as qPCR for targets of interest. So I'll just show you a little bit of that data here. So with TGF-beta stimulation, we significantly increased protein levels of PIP and PI1 in the cell supernames, and we were able to reduce the level of PIP with relaxin. I don't have the data with relaxin for these other two endpoints. Alpha SMA is also significantly induced in the cell lysate with TGF-beta stimulation. This is a nice model to help support the in vivo model, as well as being used for a screening tool for antifibrotic compounds. So just in summary, for the bleomycin model of pulmonary fibrosis, we've been able to validate 2 clinically relevant models of pulmonary fibrosis, namely the IV and the intravenous and the intertracheal models. We've shown an induction of inflammation, increases in lung weight, fibrosis by collagen detection and histology, significant changes in lung function, including elastance, vital capacity, and work of breathing. And we've also displayed efficacy using 2 positive controls, so pirfenidone and our anti-TGF-beta antibody. And lastly, we've been able to more recently develop an in vitro assay of TGF-beta stimulated normal human lung fibroblasts for a human-supported assay. And this, we believe, is a useful tool for compound screening for lung fibrosis. With that, that's all I was planning to cover today. I don't know if we have time for questions.
I think that our time is almost, is pretty much up. So any questions that were asked today, Paulette will reply to you via email, and you'll get those answers. If you have any questions after the webinar today, please feel free to email Paulette directly at pwright@biomodels.com. Thank you, Paulette, and thank you, everyone, for attending today.